The Trump administration has cut health research funding to $2.8 billion in May. That's down 28% from April. That's according to data from the Treasury Department. Joining us right now to discuss the implications is a former FDA commissioner, Dr. Scott Gottlieb.
He's 28.
It's 2.8, not 28. He's a board member with Pfizer and Illumina, also a CNBC contributor. Dr. Gottlieb, thanks for being here today. First of all, describe what happened. Why was the funding cut and where was it impacted?
Well, there's a proposed cut in the president's budget for 2026 that's quite substantial, I think on the order of $17 billion. But for this year, the NIH is very far behind their spending goals. And so they're about $2.3 billion right now behind where they would normally be if they were spending the budget that was allocated for 2025. And this is going to set up a difficult situation towards the end of the year. Either NIH is going to have to spend that money, which means they're going to have to shovel out a lot of money to fund grants towards the back half of the year, or they're going to set up a showdown with the courts about impounding that money. I think a lot of people in the administration, especially the Office of Management and Budget, have wanted to test the president's authority to impound funds. This relates back to a statute in 1974, the Impoundment Act, also a Supreme Court case in 1975 where Nixon tried to impound funds that were earmarked for the EPA. I think there's a lot of people in the administration who believe that the president has authority to impound funds. They're going to probably try to do that at some point and test the legality of both that statute and the ability for the president to exercise discretion in how money gets spent. I don't think that they're going to use NIH as a test case for that, though. They're probably going to find some more absurd form of government spending and impound that money and then go to court to test the president's authority. I also don't think they're going to do it right now when they're working with appropriators to try to pass the reconciliation bill. But at some point this year, I would expect them to do that, not with NIH money, would be my guess. And that means they're going to have to spend that $2.3 billion and whatever else they're holding on to right now towards the back half of the year. So I don't think there's going to be actually NIH cuts this year. I think there's probably going to be some haphazard spending towards the back half of the year.
So what does that mean in terms of the research that's being done right now? How does that impact what's actually happening on the ground?
Well, look, you're seeing cuts to research. Some are political decisions that the administration is making to cut certain institutions or cut certain funding. We saw a court case in Boston yesterday where a judge said that they couldn't cut grants from the NIH that were earmarked towards so-called DEI programs, that it was too overtly political and discriminatory. So that court case is going to have to wind through. But I think the reality is that a lot of the cuts that they've made or the money that they've held back, the grants that they've canceled, they're going to have to figure out a way to either spend the money on the grants that it was allocated towards or find other ways to spend it. And so I think you could see a bolus in NIH spending towards the later half of this year. I think a lot of people are anticipating that all that money will be sort of sequestered or impounded. I don't think they're going to have the authority to do that. They may ultimately get the authority to do that by going through the courts, but I don't think NIH is going to be a test case. And so what I would expect is a lot of that money to get spent, probably not on the way it was originally programmed, but spent nonetheless.
Scott, let me ask you about where things are on some of this cutting-edge research that's taking place. Yesterday, we got this news from Sarepta that a second patient had died of liver failure after a gene-editing medicine had been given to this patient. There was a lot of concern around this because the FDA kind of gave the fast-track approval to this. It's for a drug that helps with Duchenne's muscular dystrophy. That's a disease that kills boys and young men, usually by the time they're in their 20s. So a lot of questions about this. It was kind of fast-tracked by Dr. Peter Marks at the FDA over some objections of the staff. There's a new leader at the FDA who's going to be watching over some of these very issues. But for anybody who's thinking, okay, we're making a ton of progress with gene therapy, there's a lot of potential for this, that news in conjunction with the changes at the FDA have people wondering if this is going to put a freeze on what's happening there. What are your thoughts?
Yeah, look, I don't think it's going to put a freeze on what the agency's doing. I think I've heard that Vinay Prasad, the new head of CBER, who is a political appointee in that position, which is unusual in and of itself to see someone politically appointed to those roles as opposed to someone who rises up through the ranks of the career staff. He's expressed interest in some of these past approvals. I've heard he's also been taking a look at some of the pending CAR-T approvals. I think what happens if a Senate director starts getting involved in these regulatory decisions in sort of an arbitrary way that's unpredictable is it creates unpredictability in the development space, and people don't know where to allocate capital. They don't know what the agency's decision-making process is going to be. On the Sarepta issue, I would expect that they're going to review that now. Now, I don't think there was anything wrong with the way that went through the agency originally. There are occasionally these exceptional cases where you do have center directors taking an active interest in these new approvals that really establish new paradigms. And the gene therapy approvals, the early ones, were such cases. They were such products. And so the center director was involved in that approval. But this has become a bugaboo, if you will, of a lot of people who have argued that the agency in the past was too lax on some of these approvals, too permissive when it came to these gene therapy technologies and other technologies as well. There's sort of a handful of these cases that everyone seems to point to and rally around. And Vinay has done that with this approval in the past. He's written about it and talked about it. So I don't expect him to step away from that past dialogue. And I think that's why you saw the reaction in the stock yesterday from this particular company.
Yeah,
these are very important products. You've seen a lot of gene therapies. Yeah, you've seen a lot of gene therapies approved that have been really transformative for a lot of patients curing or treating certain forms of blindness, other rare metabolic diseases, inherited diseases of childhood. This one particular approval has attracted an outsized amount of scrutiny in the past, and I think that's why it's going to get reviewed.
I mean, just to look at the approval process, it was originally approved for 4 to 5-year-olds who were still walking. Dr. Marks allowed it with the broader approval so that it could go to older patients, teenagers and beyond, who were no longer walking. And maybe that's where some of the questions come in with this. But it's probably fair to point out that this is a disease that kills people usually before their 20s.
That's right. And look, when you have these gene therapies that look like they could be transformative for some of these patients, if you hold on to them, you don't approve them until you can get the results of randomized outcome studies that look at things like the accumulation of disability. In the preceding years, a lot of patients are going to become disabled. And so the agency has made an effort over many years to try to get these products, when they determine their baseline safety, out to patients sooner and then try to fully evaluate the benefits in a real-world setting. And I don't think anyone argues with that doctrine, and I don't think the current leadership does. I mean, Marty Makary, the FDA commissioner, has talked about trying to broaden the scope of those policies to try to enable rare disease drugs to get to patients more quickly. This particular drug, though, has attracted scrutiny in the past because of the process that it went through. It's been sort of written about and maligned. So I think this is a sort of test case for the scope of how much they want to intervene in the approval process around sort of discrete decisions and redecide past decisions, relitigate past decisions. I think past decisions should be settled in the absence of new information. Obviously, the death is tragic and is new information. That's why I think it will prompt a reevaluation of this.